My name is Rhiannon and today I'll be presenting the topic of left bundle branch block with a friend of mine, Betty White. We're going to be discussing what left bundle branch block is, how it works within the body and how we treat it. Basically, the setting is that we've been called to a 90-year-old female with chest pain and she's a little bit short of breath. As we arrive a short time later, we've been sent on lights and sirens. We come across this lovely lady at her front door. She's sitting down with the telephone in her hand right at the front door. She couldn't wait to sit down. When you ask her what happened, she said, "I was gardening when I got chest pain and this awful feeling came over me. It was about 30 minutes ago. I had 3 of my sprays but it didn't work, so I called you." On examination and interview, we have the following findings. She has central chest pain, tingling in her left arm, and as she said, it's unrelieved by her GTN spray. She's feeling tired today. This morning she's now feeling nauseated and a little short of breath. She's looking pale and sweaty. She's clammy to touch. Her past medical history is having angina, which is why she has the GTN spray. She takes aspirin, simvastatin as well, and she has no allergies. Her blood pressure is 103/65, somewhat low. Heart rate's 110 beats but regular. Sats 96% on room air and respiratory rate's 22, slightly elevated. She's afebrile. So with this information, we get suspicious of something going on in her heart. So we look into it and we do a 12-lead and pop a 3-lead monitor on concurrently. As we look at this, we see that the ECG doesn't exactly look normal. If we go to it and examine it in a more organised way, rather than just getting our first impression, we see that there are P waves, so it's basically a sinus rhythm. It's obviously tachycardic. We've got wide QRS complexes that are greater than 0.12 seconds. In V1, V2, we've got an unusual pattern, a QS pattern. There's no R, there's sort of no positive deflection after the P waves properly. And also in V5 and V6, which is probably hard to see, perhaps if you look in this one here, V6, there's sort of a double notch in the R wave. We call this an RR wave. I'm here to tell you that this is left bundle branch block. And this disorder can be normal in some people, but it can also indicate heart disease. It can be associated with acute coronary syndrome and AMR, and it can make diagnosing this disorder difficult because within left bundle branch block there are characteristic ST elevation and ST changes that can sort of cover up the diagnosis and be a mimic of STEMI. Left bundle branch block is a conduction disorder within the ventricles. It can occur anywhere along the interventricular pathway, but by definition, this is where it's occurred. I've just got a short video here, which I'll play for you. It shows the normal conduction of a typical signal from the SA node, down through the ventricles to the AV node, bundle of His, through the bundle branches, and left bundle branch block. The signal stops here, and instead of conducting from the left ventricle to the right ventricle, it goes in reverse. So this travels at a lot slower pace than a typical conduction pathway between the myocytes through the gap junctions. So it's going from right to left, which is why we have a wide QRS, and the notch in V6 in the lateral leads is from the delay in right ventricular depolarisation, leading to a later left depolarisation, which is the second peak, which is still bigger than the right-hand side because it's still a larger muscle. Left bundle branch block can have chronic causes or can come from an acute reason. In chronic causes it can be from congenital disorders and just degenerative heart disease. Also in the acute setting obviously AMI and STEMI can be a reason. Also pericarditis or trauma can cause this. How do we treat this disorder? In the pre-hospital setting, we're basically treating for the acute coronary syndrome symptoms. There's nothing we actually need to do for the left bundle branch block unless the patient is symptomatic. We're giving our oxygen aspirin, putting in an IV, using GTN if appropriate based on chest pain and the blood pressure, giving analgesia, giving IV fluids, if need be, if appropriate, maintaining serial ECGs and cardiac monitoring. We're also pre-notifying the hospital that we've got an unwell patient with what appears to be acute coronary syndrome with a new left bundle branch block. We're usually unable to identify this as a STEMI, so we can't pre-notify this to activate the cath lab or any thrombolysis or anything. Once we get to hospital, the patient will have their troponin checked and also perhaps creatinine kinase, and also commence any other medications that are needed for this. They might undergo cardiac pacing or thrombolysis, angioplasty or CABG surgery for an AMI. On discharge, the patient will manage with other medications and manage their any lifestyle issues that are required to keep them on track. That's the end of my presentation. Thanks very much for your time.